Here we have the dirty Duncan, or the dirty side. Obviously it has a lot less shiny appearance than the previous slide did. This on this side is where the provider is going to be checking for those cotyledons, or those cotyledons are those sections of the placenta. We want to make sure that all of those cotyledons are accounted for. If we don't have an accounting for all of those cotyledons, if pieces of the placenta appear to be missing, that is definitely going to be a concern. Without all the pieces of the placenta, there is a concern that the portion obviously is still attached and to the uterus, and that will continue to bleed, and will also lead to uterine atony, which is the prevention of that uterine fundus from firming up. So after we have expulsion of the placenta and we have all of those cotyledons, we have an intact placenta, we're going to massage that uterus until it is firm. And it's going to help constrict those blood vessels. It's going to help that fundus really do what it's supposed to do, which is to clamp down, provide that constriction, really, for those tiny blood vessels. We're going to also have potentially artificial Pitocin, artificial oxytocin or Pitocin running during this time. That's also going to help stimulate the uterus to continue to contract. So it's not uncommon for your patients to come up from labor with Pitocin still running. Oxytocin is further released naturally by putting that baby to breast. So it's not uncommon, and in fact it's very common, and it's supposed to happen when a baby effectively latches onto the breast that the mother complains of abdominal cramping. Again, that is to be expected as that oxytocin is doing its job. As a reminder, your anticipated expected blood loss for a vaginal delivery is 500 milliliters. For a C-section, it's 1,000 milliliters. Okay. I was able to watch a postpartum hemorrhage, a few minutes of a postpartum hemorrhage a few weeks ago, and during that observation period, they estimated, and this was prior to what we had in the bag, in the drape, they were estimating this mom's blood loss to be over 2,000 milliliters. So, just, obviously she was going to require careful monitoring. So then we move into stage 4. Now, at this point, we have, again, remember, 1 to 2 hours after delivery. We have a healthy baby delivered. That's the goal, remember. A healthy mom. And we're going to allow those 1 to 2 hours after delivery for not only baby to continue to transition, but mom to transition as well. The fundus of that uterus continues to be very, very closely monitored. This is the most high-risk time in post-delivery for that for that postpartum hemorrhage to occur. Things like watching for blood pressure changes every 15 minutes or so would also be on the labor nurse's radar. Some of the things that we're going to do to prevent hemorrhage, we're going to continue assessing that fundus, making sure that it's nice and firm. We're going to try to prevent any bladder distension. So we're going to encourage mom to get up and void. We're going to check for venous thrombosis as well. This is a high-risk time for those to occur. So every 15 minutes for 2 hours, that nurse is going to do a vital sign check, a fundal check, and check the vaginal discharge. It is anticipated and it is normal to see in that first 2 hours a moderate flow of that lochia rubra. Again, where is that fundus supposed to be? Is it supposed to be shifted to the right or to the left? No, it's supposed to be midline, and it should be between the umbilicus and the symphysis pubis. So you should have, especially in your charting, you should have U over 1. Okay, because we should be lower than the umbilicus during that time. And this is also a really good time to do that skin to skin. Again, if we have adoption or we have surrogacy or anything at all like that, the baby is bonding with those parents But for the majority of our deliveries, this is skin-to-skin time with mom and dad. And that concludes section 2A.